Wow, can you believe that we're almost at the end of the semester? So hang in there, you're on the home stretch. Today you should have your notes for the neurologic system, and we'll be talking how appropriate is it that your brains are probably about had it, and we're talking about tests of the neurologic system. So typical to how we do the rest of the classes, we'll start with what are the symptoms that might suggest a person has problems with their neurologic system. So we're going to be talking about the brain, the spinal cord, so the nerves, and how all those processes work together and how we might evaluate them. So I bet you would agree that seizures are not a normal finding in a healthy person, and so we might have seizures that tip us off to something going on with the neurologic system. We might have someone who has loss of consciousness or confusion, and we'd mentioned that previously on the cardiac lecture, that somebody could have something like supraventricular tachycardia, where their heart beats so quickly that the ventricles don't have time to fill and empty adequately, and so they become they have a loss of consciousness or have confusion because the brain isn't getting enough blood flow to it. So it could be cardiac in origin, but it also might be that they have a stroke or they have a tumor or something that could cause loss of consciousness or confusion. So definitely there'd be a differential diagnosis between heart versus central nervous system. A stiff neck and fever. What is that the classic symptom for? Other things that we might add with that would be photophobia. So they do better in dark than they do in light, so they have light sensitivity. And those are the classic symptoms for a person who has meningitis. Numbness or sighted weakness, so we're trying to get the word out of symptoms to look for in stroke. It could be loss of balance. It could be that we have them smile and they can't raise both sides of their mouth equally, or we have them put their hands above their head and they don't put both hands or arms up equally. So sighted weakness suggests something neurologic like a stroke, and frequent or very painful headaches. And we'd be trying to differentiate here something like a brain tumor or increased pressure in the head. There are some people who just have abnormalities in the recirculation process associated with cerebral spinal fluid. I guess I didn't realize till later, I don't think I picked it up in A&P, that our bodies are constantly producing cerebral spinal fluid, and they're reabsorbing that. And so if there's a problem with that reabsorption mechanism, we could have increased pressure build up in the head that would cause painful headaches. So just a little humor. Hopefully if we scanned your brain, we could find something. But let's look at some of the procedures we might do. So not a great quality slide, but pretty much the best one I found as far as a graphic of showing with a spinal tap or a lumbar puncture. We have a person lay on their side and kind of curl into fetal position. As you can imagine, that would spread out these bony processes in your back. That would better allow the physician then to access the space between those vertebrae. And we're going to use your lumbar area, therefore the name lumbar puncture. We're going to use the lumbar area of your vertebral column because we should be below the level of your spinal cord. It's always a risk, though, even though it's rare, that we might cause some sort of paralysis by doing a lumbar puncture. So it's a very invasive procedure. It is the diagnostic test to differentiate the cause of seizures. If we think someone has meningitis, this is the test that we perform. So we might do a white blood cell count to check for infection or inflammation, but we're also going to do a lumbar puncture, and we're going to look and collect some test tubes. So if you've had the chance to watch this procedure, hopefully it wasn't done on you. They collect little test tubes that contain your cerebral spinal fluid, and in your notes it talks about the specific things that we would test for. We're going to look at, I guess let me stay here for a minute. They're going to do collection of fluids to measure protein levels, to measure glucose levels, to do cellular counts. We had our lecture on microbiology, gram staining, culture and sensitivity. So they're going to send it for those, and we're going to save a fourth test tube that we can do testing on later. If we decide maybe we need to get fungal cultures or something, or we need to do some other further testing, we're going to preserve one of those containers in a storage area so that we could access it if we need to without poking you again. So what things could help us? Well, we look at the cellular counts, and white blood cells are made of protein. So if your protein level goes up, we know that we have a pretty significant attraction of white blood cells or cellular debris there. If your glucose level, it's kind of interesting that if you remember clear back to the lecture on diabetes, I shared with you that our brain uses about 1/3 of the glucose in the blood. And so can you imagine that if I take your blood glucose and I take your cerebral spinal fluid glucose, normally they should be about the same level. But I want you to look in your notes carefully and look at the difference in glucose level and the difference in protein level when we're trying to sort out, do you have bacterial meningitis or viral meningitis? And the reason we want to do that is viral meningitis can be pretty much self-limiting. It goes away on its own. In fact, if you had a bad headache and were ill, you might have had meningitis and you just kind of wrote it out. Bacterial meningitis, on the other hand, is associated with horrible complications such as DIC, that diffuse intravascular coagulation, and sepsis, moving to your bloodstream. And we want to put you in isolation if you have bacterial meningitis because it is something that can be transferred in your body fluids to other patients. It's transferred by droplets. And so that would be an important differentiation, and I bet you'll need to know that, huh? So would you look in your notes and make sure you understand what will happen to my glucose level, what will happen to my protein level if I have meningitis, and could we sort out whether it was bacterial or viral? Okay, CAT scan. So now we move to kind of a non-invasive way to look at the brain. We can also do a CT scan of your spine. So we could look for places where the discs, the padding between your vertebrae bulges out and kind of impinges on a nerve. The brain is made of soft tissue, and we've mentioned in this class that usually x-rays, which the CAT scan uses x-rays, are not very good at looking at soft tissue. However, they do show us density. So I bet you can pick out the brain has gray area and white area. We have gray matter and white matter in our brain. And it actually kind of looks that way on a CAT scan. So we can see the sulci of the brain here just by looking at the density. I can see the hemisphere of the brain. And to remember that anytime you look at an x-ray, it's as if the person is facing you. So this would be their right. This would be their left side of their brain. And so I bet you can pick out the abnormality here. You can see this increased density here. And when things are that white, do you remember what that represents? Is that fluid? Let me give you a hint. Here is the ventricles of the brain, and they're filled with cerebral spinal fluid. So do you remember that fluid or air will be dark, and solid or dense things like bone, here's the skull. Look how white that is. So this area of tissue is as dense as bone. It could be an old bleed that is healed. When the brain heals, it leaves behind, I guess the brain doesn't leave it behind, there's calcified lesions. So you can have calcified lesions that represent old brain injury, whether that was bleeding or trauma. It could also represent a tumor that is very dense. Now, a lot of our brain tumors are vascular. They're they would be less dense because they would have a lot of blood supply in them. And so this probably represents an old bleed or a very solid type of mass. Can you see how it's kind of pushing against that ventricle in the brain, though? It's not really pushing over this hemisphere of the brain, but it's starting to kind of spread as this gets bigger. Can you imagine it would put pressure on that side of the brain? And so this person might have right-sided abnormalities on their body because the left side of their brain has a lesion. Here's a CT that shows where a location of a bleed is. So here's brain, and this isn't a great quality one. This does show that hemisphere getting pushed over, though, because of this blood that is under, so the term subdural, it's under that thick covering of the brain. So this area of bleeding is between the skull and the brain itself, under that thick covering of the brain. So doing a CAT scan, if someone's had a stroke, it's the first procedure we're going to do on them. Just like a person who had a heart attack, we're going to do an EKG the minute they roll in. If someone's had a stroke, the first procedure they're going to get is a CAT scan. It will help us identify the location of the bleed and the type of the bleed in most cases. Here's an MRI. Do you remember that MRIs use that big magnet, and they see soft tissue with much better detail. So we can actually see the pons, the medulla. We can see all the different sulci of the brain with much more detail than we did when we did a CAT scan. So a cerebral MRI might be the way to go. The bad thing is, in an MRI machine, you have to hold perfectly still. So if you were having seizures, do you see that an MRI might not be an option for you? MRI machines are typically more difficult as far as scheduling to get people into them. MRI machines are much more expensive, and so it's more likely that a hospital, especially a smaller one, would have access to CAT scans rather than MRIs. MRIs might be used on a mobile basis where they're on a truck, and they maybe go to your facility once a week or something. And so CTs are going to be pretty much the norm, with MRIs being used in special circumstances. If we do think it happens to be with the tissue of the brain, an MRI would be a better way to go. But this can be really confusing to patients. I know that I've had some family members, they said, hey, the doctor sent me for a CT, a CAT scan, and then a day later they turned around and had me go get an MRI. And they say, you know what, I bet they're just doing that to rack up my bill. They saw I had good insurance, and so they're hitting me for all they can. And what it may be is, if you think about it, we said some lesions may be more dense, and I could see those pretty easy on a CT. But what if I need fine details before surgery, or we thought we would best see the lesion with CT, but it didn't turn out that way? So it's not unusual that we might start with one procedure and then do another one. It does get a little sticky though, because MRI machines, when they first came out, and CT scans also, guess who owned them? Guess who purchased them? Well, the people that purchased them or went in as cooperatives to purchase them were usually the physicians who use them. So it did get a little skeptical of people saying, wait a minute, are you ordering this procedure because you own the machine and you're trying to pay it off, or you're trying to justify it? Or are you really ordering this procedure because I need it? And we'd hope that we have ethical physicians who are doing the procedure because they really need the data. But that's always an interesting dance as we look at these cooperatives that have kind of purchased either private MRI centers or private radiology groups. It usually is that they stand to benefit then by ordering those things. And so I think they have to be extra careful to always ask themselves, why am I ordering this procedure? And it's always a good question as a patient to ask, why am I having this done? What data do you hope to learn? How will this impact my care? So it's good to ask those questions. But I think you can appreciate, do you see how we could assess someone who has a sinus infection? Here's your sinuses. We could look at the throat. We've looked at this for other procedures too, but MRI is nice for soft tissue. They do help us evaluate bone, but they see that soft tissue so beautifully. Okay, here's a patient who had a CT, and this is a repeat slice as we go down the head. So aren't those eyeballs kind of cool? And you can see if they have a deviated septum, it looks like they might breathe better through this left nair than they do their right nair. And you say, wait a minute, didn't you get that backwards, Jody? Do you remember it's as if the person's facing you? So this would be left, this would be right. As we slice up through those structures, we might see some differences like this, and we could say, well, is that pathologic? Is there something wrong? Or is it just that the patient's head is turned a little bit? So we see more of this ventricle than we do this one. I would bet, though, you could pick out these lesions like this and these big lesions like this that are not normal. And there are patients who get fungal infections in their brain. I bet you can imagine that you could breathe in a fungus and that it might somehow find a way across the blood-brain barrier and cause a fungal infection in your brain. It might also spread there through the bloodstream. But we can have fungal infections, and the way they'd know that is to do a culture or the way it presents. Can you see that this lesion has a very dense area, but then it has this kind of area that looks bubbly up here? So sometimes the way things present help us know what the likelihood is of what caused them. This is called a myelogram, and in your notes, I would think of a myelogram as a reverse lumbar puncture. With a lumbar puncture, we were taking fluid out. With a myelogram, we're putting a needle into your spinal column, and then we're injecting a dye, a contrast media that will let your spine show up when we do a CAT scan. And the purpose of doing that, because it is very invasive and risky, is we're going to look at that detail of these nerves that come off your spinal cord. So this is a patient typically who's complained of long-term or fairly severe back pain. Now it's moved to numbness and tingling. Maybe we've even noticed that the thigh diameter on one leg is smaller than the other one, meaning that it's starting to atrophy. That nerve function is not as effective as it should be moving to those muscles. And so the physician has decided he needs to do surgery to fix that. We've got enough symptoms that needs to be repaired, and the physician wants specific detail about these nerves and where that damage might be. So the bones have kind of been shadowed out of this, and we are really looking at that spinal cord with these little nerve roots that come off of it. And so your bone would be here with your discs, and it's usually a bulging disc or something, or maybe even a broken bone in your spinal column that would cause that damage. We could use the same sort of procedure in someone who's had a spinal cord injury. If they were in a car accident or something and we think they broke their neck or they broke their back, we use that term. We'd look to see if the spinal cord has been separated, meaning that they are going to be a paralytic. Yeah, that would be a correct term, I guess. But because this is a very invasive procedure, if I had a family member or if I was told that I need to have a myelogram, I'd say, wait a minute. They're looking at soft tissue, so can you think of a procedure that might be able to help you do the same thing and do it in a less invasive manner? So I hope you're thinking MRI, MRI. I would pay the additional cost to have an MRI to have a lower risk. Now, that would be a question I would ask the physician, though. Do I need to have a myelogram? Is it because you don't have an MRI available? And if they said yes, I say, could you refer me to a center? Because I'll happily go to where I need to go. Or is it that you're going to get a different piece of data by doing the myelogram than you would an MRI? So the MRI could do the same sort of thing, and with MRI we can give you some type of a contrast just in your blood vessel rather than injecting it into the spinal column, or we could do it without contrast. Okay, and EEG, we've had EKG or ECG, that was electrical activity of the heart. Now we have EEG, an electroencephalography. So we're going to record the electrical activity of your brain. And a technician would come in, and it takes quite a while to hook up these little electrodes. They now have little caps that they would put on your head with holders, or they come in with a little adhesive and they actually attach these in specific locations across your skull. These attach to the outside so they can kind of part your hair. It's not that they have to shave an area on your head. They can part your hair down and attach these electrodes where they need to be. The data that's recorded on those, it has multiple leads, and this to me kind of looks like those sleep studies that we looked at when we did the respiratory system. If I look out here, it would tell me the location of those. They would correspond it with the cap on the head or the location of those probes. They would then record the information, and their technician would make notes when there is noise. So the technician might make loud noise to see how the brain reacts to that noise. They might look for evidence of seizure activity as they're doing the procedure. So the number one reason for doing an EEG is because someone's had seizure activity. It helps us determine, is what we're seeing really seizure activity? There are sometimes, especially with things called subtle seizures, that it's hard for us to differentiate, is that person really having a seizure? And so EEGs are done to determine if people have seizure activity. It's then used to diagnose epilepsy. EEGs are also used in most states to show brain activity when we're talking about brain death. And I really have never seen an EEG that is flat. So we talk about the EEG was flat. We say that it was not reactive, but it's really never flat. As you can imagine, your brain is always doing something. But there are normal patterns and there are abnormal patterns. And so by creating that noise, can you imagine they're looking to see, did the brain's electrical pattern respond appropriately? When they had a seizure, did the brain activity change so that we do feel comfortable saying, yes, that was seizure activity. So to diagnose epilepsy, to determine brain death, and to determine if someone truly is having seizure activity. Now let's move to an invasive. As you can imagine, this one was pretty non-invasive, huh? Just attach probes to the head. Now we move to a very invasive. We're actually going to do angiography. We're going to put a catheter up into your blood vessels. So if we're studying the arteries, we're going to put it up into one of your carotid arteries. And as you can imagine, that's pretty risky. Most of us have some sort of plaque that's built up on those blood vessels, and when we put a catheter in there, we always run the risk that we might dislodge some of that plaque and actually cause a stroke. Then, so we're very careful and mindful of that. But this patient has had contrast media injected into an artery, and we see this beautiful outlining of the structure called the circle of Willis. So these things to me are amazing. This is a test, catheter angiography or cerebral angiography. Remember, angiography was a term about studying blood vessels. This would be done to look for brain tumors. Most of our brain tumors are very vascular. It's a procedure that could be used to look for an aneurysm, a weak spot in a blood vessel. So can you see? We can see twisted areas, blocked areas. We have used this term before, angiography, when we talked about cardiac angiography, or we could do venography, where we're studying the veins, or arteriography if we're studying the arteries. This is the temporal artery of a person. So now they're looking forward, and you can probably feel that temporal artery right above or kind of on the side of your head, where if people act like they have a stress headache or something, I know if I wear sunglasses too tight, my temporal artery gets compressed and I have a little spasm and develop a headache. So we can look for dilated areas. We could look for overly vascular areas that might represent a tumor. We could look for narrowed areas. MRA. So we've had this term before with the cardiac system. Magnetic resonance angiography. When we put the A behind it, it means we're studying the blood vessels. So in a less invasive way, again, I would ask the question if somebody wants to do a catheter angiography on me. Wait a minute, do we have to do that? Couldn't we go to something that's a little less invasive? And that procedure might be doing MRA. The downside is, do you see that what they found in this patient? Here's that nice circle of Willis. But we have an artery here that's not getting blood supply to it. And so therefore this brain tissue may not be getting the blood supply to it. The advantage of doing catheter angiography is now I could move in there with my catheter and maybe open this area back up by putting a stent in. If we have an aneurysm, I can put in a coil so that it would block off and make that area more stable. So the advantage of catheter angiography, even though it's much more invasive, is it can be diagnostic and therapeutic, whereas if I do an MRA, I can find what's wrong with you. I may not be able to fix it without doing a catheter. Now, if this was a stroke and this represented a blood clot, we have a medication called TPA, tissue plasminogen activator. It breaks down clots, and we've talked about that before. It does not have to be delivered with a catheter right to the spot. It's kind of magical that it will find where it needs to work. And so it may be enough that if we diagnose this, we still can just give you an injection in an IV, and it will go to the area where it's needed. But if it were that we need to put a stent here, that's a different story. So what are those advantages of MRA over angiography? So I don't use a contrast media, or I use a safer contrast media if I do MRA. We don't have to worry about dislodging that plaque. Believe it or not, MRA is less costly than catheter angiography. And angiography uses fluoroscopy. While we're doing the procedure, we're watching it on a moving X-ray. So you are being exposed to X-rays if you're having an angiography done. And because there wasn't a catheter placed, we don't have to worry about you bleeding once that catheter's been removed, because with MRA, if we did use contrast, we just put it in through an IV. We didn't have a catheter up in an artery. As you can imagine, the pressure and time that we have to keep over that area where the catheter was put in if you had an angiography. But what are the drawbacks then? Because it would seem like if I get the choice, or even if I don't get the choice, I'd know to say, or I'm advocating for my patient and saying, couldn't we maybe do the same thing with an MRA? There are certain types of patients, if you have a pacemaker, the way that we reset pacemakers is with a magnet. So MRI and MRA, they use the big magnet. If I have metal in me that is magnetic and will migrate during the procedure. So there are some people who are screened and cannot have MRIs, and that is, I know that my father-in-law has a pacemaker and he was told this will mean that you cannot have an MRI done. The images, the sharpness of the images, the ones from angiography are definitely preferable. And like we said, it may be that I can do diagnosis and treatment when we're doing the angiography as opposed to an MRI procedure. So I hope you understand those issues. Okay, let's do a very non-invasive thing. We're going to do Doppler imaging. So when we did a Doppler image or an echo of the heart, we called it echocardiography. We can study the blood vessels we can get to. Now, I can't do an echo of an adult's head. The skull gets in the way of the sound waves. But do you remember that babies have a fontanelle, a soft spot where their skull has not fused shut yet? We can do ultrasounds of babies' heads. So if I were looking for abnormalities in an infant, I could do ultrasound. That would be a great option if adults had an opening in their skull that we could do ultrasound, but they don't. And the skull blocks the sound waves, and so what we can study in adults is blood vessels we can get to that don't have bone over them. So we could do the carotid arteries, and we could look for blockages. Like I said, there are a lot of us who, even if you're leading a mostly healthy life, but especially if you're a smoker, you're going to have quite a bit of plaque that has built up in those blood vessels. And that is why smokers are more at risk for stroke and heart disease, is because that plaque that builds up. And you can imagine if I have plaque here that breaks loose, I have a stroke. If I have plaque that gets narrow enough and I don't receive blood flow, I have a stroke. Excuse me. We can do Doppler scanning then and look at that openness of the carotid artery, or we could tell you what percent blockage it is. We do have a procedure if we find a pretty significant blockage called Carotid Endarterectomy, where we go in and we kind of scrape out or bypass that narrowed area. And as you can imagine, there's a risk of that plaque breaking loose, and so before they do the procedure, they put a filter that would kind of trap any things that get loose as they're kind of cleaning that area out. All right, we're headed towards the end here. We are now to electromyography procedures. And the reason this ties in under the neurologic section is you can see that this person is at a keyboard and they have some probes that have been placed. So we have a fairly common diagnosis because of all our repetitive motions with our hands, either from grocery store checkers or people sitting at a keyboard for long hours, or people who do number coding. That is carpal tunnel syndrome. And carpal tunnel syndrome involves inflammation of that ligament and nerve as they run through their little channel on your wrist. And so what this person's having done is an evaluation for that. We're going to put an electrode here and some electrodes here. And we could do these on the leg if we were looking for conditions that involve the leg. We are then going to send through signals through these probes, and we're going to measure through those probes. So we can send out electric signals and we can measure signals. So if I send a signal here, do you imagine that that should stimulate the nerve and I should get some sort of signal here? What we're looking for then is, let's say I had a back injury and I think I have a pinched nerve and my doctor thinks I have a pinched nerve, but they want to know if the problem is that the nerve is damaged or that my muscles aren't working. So let's take a condition then to contrast with that as opposed to a nerve injury. What if I have something like multiple sclerosis or muscular dystrophy, something that actually attacks maybe the myelin sheath of a nerve. And so my nerves are what's not working. The spinal cord or the brain is sending the signal, but my muscles and my nerves can't respond. That's where EMG comes in. It's going to tell us if you send an electrical signal, are the muscles capable, myography, are the muscles capable of responding? So if I send a signal and the muscle works perfectly fine, then I know the problem is the brain or the spinal column. My central nervous system isn't sending the signal correctly. If you send the electrical signal and my muscle doesn't respond appropriately, now you know I have a problem with the nerves in this area or the muscles in this area. And that might be something like myasthenia gravis or muscular dystrophy or multiple sclerosis or carpal tunnel syndrome. So here's a person having EMG done of a lower limb. Again, we're going to send out electrical signals. We're going to measure electrical signals. We're looking at the muscle's response to electric stimuli. Is the problem with the muscle and the nerves here then, or is the problem with the central nervous system not sending the signal? That's how EMG testing will help us. Now some really cool stuff. So there's some interesting procedures coming. This is one that we've had around for a little bit. Functional MRI. So functional, what if I put you in an MRI machine and then I have you do math problems? Or I have you remember dates, or I have you count, or I have you tap your fingers. As I have you do those things, the part of your brain that controls that activity should light up. And so if I were to say brain mapping, could you see how they might do that with a functional MRI? So why would this information be helpful? Well, what if you have a brain tumor and we're going to operate on it, and you ask us, hey, what am I going to be able to do, or what am I going to lose my ability to do after you remove this brain tumor? By having brain mapping done of a variety of patients, we can better be informed of what parts of the brain control what activities. And so a functional MRI might be used to diagnose somebody who has Alzheimer's. It might be used to diagnose someone who is going to have an operation and wants to know what parts of my brain are going to be impacted. So we look at blood flow to those areas, and that should be the area that's controlling that function that we're having you do. Okay, functional MRA, we're focusing on the blood vessels now and blood supply, and a PET scan. So by far right now, PET scan means positron emission testing scan. The current most common use of PET scanning is to either stage cancer, I guess I shouldn't use the word stage cancer, to either look at the effect of cancer treatment to see if your cancer is getting worse, or to see if it's responding to therapy. Right now, we used to use, I guess previous to this time, we used to use CAT scan or MRI to look at the size of a mass. And about the only way we could tell if you were getting better was the size of the mass got smaller. Those procedures only helped us look at sizes of things. PET scanning looks at metabolic activity of things. So I'm going to have you come into my lab, and it's going to be that not everybody has this available. We're going to give you a very expensive IV, and that very expensive IV is radioactive tagged nucleotides that are glucose-based. So remember that your body's going to burn sugar for energy. So if we go have you run after doing that, can you imagine that glucose is going to be all over your body? And so those radioactive nucleotides would be everywhere. So we're going to have you do just the opposite. You're going to lay down. You're going to lay still. We're going to make sure we keep you warm so that your body doesn't have to work to keep you warm. We're going to inject that nucleotide into you, and we're going to see hot spots. We're going to look to see where do those radioactive nucleotides of glucose end up. What is metabolically active in your body? So I'll bet you can tell me what's a metabolically active structure that's going to be here in the center part of your chest. So I bet you could guess heart, huh? What's going to be a metabolically active structure that is in this area of your body? So we have kidneys and we have bladder. what they're looking for is areas that show up. Can you see this person's brain has some? So we're looking for areas where it shows up that we know should not have that amount of metabolic activity. And the pictures now are all colored, and so we can kind of pick out this had very high metabolic activity, this had lower metabolic activity. But it helps us then if you had lymph nodes that had metabolic activity, even though they haven't shrank in size, if there's no more metabolic activity, we know that we've killed those cancer cells. And so it's used after cancer treatment to see if you responded and do you have metabolic activity or not. As you can imagine, there's kind of a threshold level that if you had 3 cancer cells that are still metabolically active, they're probably not going to take up enough of this glucose radioactive nucleotide that we're going to see it. It's not enough. So you're going to have, you could still have cancer, but we can't detect it yet. Another use for PET scanning is to screen for cancer. If you can afford this, like an Oprah of the world, she, I believe, goes and has a PET scan. I think she said on our one of her episodes, she goes every year for an annual PET scan. So she can afford to pay for this $40,000 procedure or more, that they're going to look for cancer. Most of us can't afford to screen for cancer this way. So it's going to be used to identify where our cancer has spread to. Is it in the bone? Has it gone to all the lymph nodes? And more probably commonly, is it going, after we've had cancer treatments, we'll do a final PET scan to see if there's still metabolic activity. So I hope you have a better understanding of the neurologic system. Thank you for joining me for this lecture today. And I even got you out of here early. So thanks, guys.